one chapter which is congenital. And all of the cases which I show in this course have either come in the exam or can come in the exam questions, etc. We've got a lot of experience there. And this type of teaching is quite unique because it builds your, the take-home points is what we are going to give you. Today, my aim is to cover chapter 2 and 3. But I've got something to teach you today, and which is how to tackle a differential diagnosis case in the exam. So that will take a bit of time. So if my aim is to cover both of these, we have lost 10-15 minutes. Let's hope that we are able to finish it. I will be following Chapman, and all of these courses are based on Chapman. And I'm following the 7th edition. If you don't have the 7th edition, don't worry. But usually I advise my students to have this Chapman with yourself. And I'm a fan of what I use the word book memory. So during the course, whenever a differential diagnosis comes, open the page number which will be on the slide and refresh yourself later on. Try to learn. Right. So if candidate number 1 can unmute yourself, and if you can acknowledge that you can hear me, candidate 1.
Hi, I can hear.
Okay, this is your case. Over to you.
Frontal radiograph of a patient with an immature skeleton and complaining of tenderness in the left hip. So I can't see any bony abnormality or fracture, but there appears to be a lucency in the proximal metaphysis of the left femur. There is a surrounding sclerotic rim. I can't see any aggressive periosteal reaction. I can't see any evidence of effusion in the left hip. So given this appearance of lucency in the metaphysis, I would be concerned about a possible infective cause such as a Brody's abscess would be a possible differential. I would correlate with the patient's history to see if they have any fever or sepsis and proceed to MR.
Before MR, can you do anything else?
You can also do an ultrasound of the hip to see if they have an effusion in the hip.
That's the correct answer, because you can also tap it, right? So that's the correct answer. And are there any signs of effusion on this plain film?
I think there's some obliteration of the fat planes on the left compared to the right. It appears to be a bit more.
So can you name the fat planes around the hip joint for me?
I only know 3. There's the iliopsoas fat plane, which is sort of inferior medial to the hip joint. The capsular is more lateral, and the obturator is the medial one. And I think the obturator one on this side appears to be abnormal.
What do you mean abnormal? Is it distended? Is it obliterated? What is happening?
It looks a bit distended when you compare it to the contralateral sides.
Right. And what about the capsular or the gluteal fat plane? If you compare it with the right side, though it is a subtle finding, but do you feel that that is also slightly distended?
Yeah, I think I see it now slightly more compared to the right side. There's some subtle changes in the capsular fat pad as well.
Right. Okay, thank you. I'll show you more cases, so you remain with us.
Sure.
Now, a few teaching points here are that around the hip, 3 fat planes should be recognized by yourself. This is what we call the capsular fat plane or the gluteal fat plane. This is the obturator fat plane, and this is the iliopsoas fat plane. Now, infection in this age group, between, so interestingly, babies less than, let's say, 1 or 1.5 years, or sometimes up to 2 years, they have got epiphyseal. They will usually have epiphyseal infection. But between the age of 2 and 16, usually the infections are metaphyseal. And you have to develop your eyes. This should be a, in pediatric age group, this finding of the metaphysis. This comes and has come in the exam many a times. And so there is an infective process, and there might be some sclerosis or might not be any sclerosis. Distension of the fat planes should be something which should be your pertinent negatives or positives in the exam. So distension, pertinent negative or positive means that it has, you have to tell the examiner that if they have distended or not. Another word which you should be in your vocabulary is obliteration of fat plane. So sometimes what happens is that if you compare right and left, there might be, the fat plane might be lost. And that is also taken as a sign of infection. Look here, there is another case here where similar finding. If you see here, lucency here, and very difficult if you are not very careful, because there is a lucency, but then you realize that there is a bit of sclerosis. And the fat plane, look at this capsular fat plane, and you will agree that as compared to this one, it has slightly distended. So this is the concept that from here, what can happen, the infection can go in, and you can do an ultrasound examination and do a diagnostic test. This is just an MR just to confirm that this is what it was. Now, look at this picture from a textbook. And here I just wanted to show you the same thing, but another example of obliteration. So you can see, look at the fat here. Because fat is low density, this is all black to your eyes. On the other hand, that blackness is lost. So there might be distension, but there is obliteration. And again, this subtle finding, though the resolution is very poor. Another thing which you can see is that this femoral capital epiphysis, if you see this distance, it has increased. So this is a very, very favorite type of a film which has come in the exam again and again in a pediatric age group. Okay, candidate one, once again your case. So this is not PEDS, 37 years old.
Frontal.
I found a pass on the floor for some.
Skeletally mature 37-year-old male patient. So there doesn't appear to be any bony injury or fracture. Comparing the left hip to the right hip, there appears to be increased sclerosis of the left femur with obliteration of the obturator, capsular, and iliopsoas fat pads. I can't see any bone lesions, periosteal reaction, or other abnormalities. I see a lucency in the left superior pubic rami. However, I think this represents bowel gas. In summary, I'm concerned about the left hip effusion in this patient, and I would further evaluate with an ultrasound.
And any other evidence? You've picked up one finding, so I agree the finding is there. Any other evidence that something is wrong? Look at the joint space, please.
So the joint space is significantly narrowed compared to the contralateral sides. So there's loss of joint space as well, which will be in keeping with a possible infection in the left hip.
Right. So if you see here, the key point here is compare this joint space with this joint space. Now, this joint space is obliterated. Look at the acetabular margin, and which is normal sclerosis there. And you can see that on left side, that sclerosis is not present. And you can see a bit of lucency here. So it means that these are signs of septic arthritis. Of course, you picked up the obliteration, etc. But overall, this is a subtle finding of septic arthritis. Okay, candidate one, once again, please.
Onto a natural radiograph of a patient with a skeletally immature skeleton. In the distal radial diaphysis, there is a lucent central lesion with a narrow zone of transition. There is surrounding increased sclerosis. I can't see a periosteal reaction. It doesn't appear to involve the cortex of the bone. There isn't a soft tissue component. The ulnar carpal bones and the remainder of the hand appears to be normal. So overall, I'm concerned about an aggressive process in this lesion, either an infective process or a malignant process. Given the location and appearance, I'll be mostly concerned about an interosseous abscess or collection in this patient.
So what is your differential there?
So it has a narrow zone of transition. It looks aggressive overall.
Has it got a narrow zone of transition?
Has it got a narrow? I feel it doesn't have a narrow zone of transition.
Doesn't have. Okay, good.
Sorry, it doesn't have a narrow zone of transition. So overall, has an aggressive appearance. So my differential to include malignancy, Langerhans cell histocytosis. Metastasis will be very uncommon in this age group.
So what else? Which further malignancy?
It doesn't look. Osteosarcoma tends to involve the metaphysis more. Ewing sarcoma, possibly, but again, less likely.
And why do you say less likely?
It just has a more typical appearance of an abscess to me. It's very central. There's no cortical or periosteal reaction. There's increased bone sclerosis.
Look at the lateral. Do you see any periosteal reaction there?
On the dorsal aspect, there appears to be some cortical thickening.
Okay, I'll take over. Thank you. Well done. Now, if you see this case, this is classical exam case. Classical. First take-home point is that when you see a lesion like this in the exam, or never use the word in your description, benign, malignant lesion, use the word aggressive lesion. When you use the word aggressive lesions usually are two types. One is infection and second is malignancy. Now, this age group is very, very important age group for the exam. And please remember that two things, they go together. One is infection, always will go with Ewing sarcoma, always. And even clinically speaking, Ewing's at times has got raised ESR and fever, etc. Candidate one, what will you do next?
So I think this patient needs an MR to further evaluate, and that would correlate with the patient's symptoms if they have the inflammatory markers. But I think an MR.
I'll take over. Thank you. So, is that the MR can specific diagnosis, where MR can help you between benign and there will be cases in which MR will be able to give you a black and white diagnosis. And cases in which you will still be in doubt. So MR is the answer. Now, if you see here, this lesion has got a white zone of transition, and rest of the description was fine. If you see here, there is a bit of periosteal reaction. Now, candidate 1, I'm showing you the MR of this patient. What do you? I am going to point out, and you tell me what sequence is what. So just let me give you a hint. It's better to look at the carpal bones here on this one. What do you think is this sequence?
T1.
Okay, so what is this?
Fat sat image, T1 fat sat.
What is this? This is T1 fat sat.
T1 fat sat post contrast.
And this is T1 fat sat post contrast. This is a stir sequence, right? So can you please describe and tell me what it is?
So there is a lesion in the distal diaphysis, which is high signal on stir and relatively low signal on T1. There is a surrounding thick rim, which appears to be high signal on T1, low signal on stir, and demonstrate enhancement on the post-contrast images. There also appears to be a satellite nodule more proximal to this lesion. There's significant edema surrounding this lesion, bone marrow edema, which extends into the distal metaphysis. Overall findings are in keeping with a Brody's abscess.
Okay. You can mute yourself, candidate 1. Thank you. Now, if you see here, when we do musculoskeletal imaging, we do a T1 weighted sequence. T1 weighted sequence is a king sequence to see marrow abnormalities. I'll show you MR spine also. And anything which is dark on T1, because usually there is a bit of fatty component of marrow. It all depends on age of the patient. Anything which is dark on T1 is a bad sign. And then comes the subjective phenomena, how dark. So if something is darker than the adjacent muscle, or in spine imaging, if something is darker than the adjacent intervertebral disc, you have to think that something is happening. And this kind of marrow abnormality is then correlated with a stir sequence. Those of you who are ST1s, stir is short tau inversion recovery. It's a physics term. And this sequence, by definition, is a fat saturated sequence. So water is very well seen there, and edema is very well seen. In some parts of anatomy, we use it. And in MSK and spine, it is extensively used. It is also used in head and neck, for example, but we don't use it in the brain. So this is a T1 weighted sequence. This is a stir sequence. And this is a fat saturated T1 weighted sequence. So please remember, whenever we do contrast, we have to do a pre-contrast fat saturated. And on post-contrast, you can see this rim enhancement. And on other axial sequences, you can see cortical breach here, and you can see a lot of edema. So this is a classical Brody's abscess, and it's not Ewing's or anything like that. There is a sign here on T1 weighted sequence, which I will come back to, which is known as penumbra sign. It is visible here, but I'll show you. Can you please mute yourself? Now, if you see this case, just to show you the penumbra sign, which was visible on the previous case also. But what is penumbra sign? Penumbra sign, by definition, is seen on a T1 weighted sequence. Remember that. So this is a sign which is considered very specific for abscess. And what happens is, in an abscess on a T1 weighted sequence, the margin of the abscess, which is this thing, has got slightly higher signal as compared to the central portion. If you give contrast, this will enhance. In this case, from Radiopedia, there is no enhancement, no contrast enhances, sequence is present. But let's go back to our case, which was this one. And now you can see this penumbra sign. And in the exam, if you pick up this penumbra sign, the examiner is going to give you maybe an extra mark or half a mark or things like that. Please remember, each case is you have to get any 6+ marks. So if you tackle it better, examiners might give you 6.5 or 7 or 7.5. And the idea is to compensate for any other case which you could not do very well. So the penumbra sign is visible here also. And in this case, you can see there is enhancement. So another case of Brody's abscess. Brody's abscess might have sclerosis and might not have sclerosis. Okay, if candidate 2 is with us, please unmute yourself and acknowledge that you are with us.
Yeah, can you hear me, Dr. Khan?
Yes, I can hear you. Please, this patient is in the ward, dementia, fever, bed sores. Over to you.
Okay, so I've got a frontal radiograph of the pelvis in an 80-year-old female presenting with fever and bed sores. And I can see there has been a destruction of the right femoral head, the right inferior pubic symphysis, and the left inferior pubic symphysis, because I cannot trace an outline around the cortices of all of these three. I can also see that the fat planes on the right are disrupted. It almost looks like there's an ossification overlying the right femoral head. I'm trying to think whether this is the avulsed fragment or whether this is just a heterotopic ossification that I'm seeing. Other than that, the sacroiliac joints are congruent, no abnormality there. The left hip joint is congruent. The joint space is preserved. And then there's a right superior pubic ramus fracture as well.
What is your conclusion?
So I think there has been the way the destruction is, I'm thinking whether there has been an underlying infective process with erosion of the head and the soft tissue.
Sorry to cut you. Is there any definite sign of infection? Look at the right hip.
So there's the right femur has a mottled appearance, and then there's also this lucency projected over the soft tissues
So
there.
what is this lucency? Good.
I'm thinking whether there's an effusion there.
So effusion will be low density? This is low density, right?
No, it should be higher. Yeah, it should be higher.
So
whether there's air there,
and if there is air means what?
Thinking about whether this is an emphysematous osteomyelitis, which has resulted in destruction of the bone.
Okay, well done. So I'll take over because of the time factor. Good. The main thing here was to pick up this ear, and if you see this ear, it is low density. It is not gut or anything, right? It is, and means it's a black and white sign that something is happening. So this was septic arthritis. You can see on a T1 weighted sequence, ear is similar, and these are the same sequences which I showed you in the previous case. This is post contrast, and ear is there. So this was an observation type of a film. Observation means the film is easy. We can see gross findings there, and we can pick up. But this finding clinches the diagnosis on a plain film. Okay, well done.
Thank you.
This case is okay. You describe it, and then I'll just ask you a few questions.
Okay, so I've got a frontal radiograph of the chest of a 15-year-old, and I can see there's a lucency projected over the right hemithorax. It doesn't appear
Forget
like...
about this. This is projectional. Just concentrate on the strip, please.
So I can see on the right posterior rib, there is a lucency. There is no associated soft tissue swelling that I can see. The cortical margin, the inferior cortical margin is preserved, but looking at this, it looks like the superior cortical margin is disrupted. The rest of the imaged ribs appear unremarkable, and the surrounding soft tissues appear unremarkable. So again, in a 15-year-old, I would consider underlying infection, underlying LCH, and primary bone tumor would be on the last, or multiple myeloma would be at the bottom of my list. My main would be an LCH and Ewing's granuloma, which is seen in LCH and infection.
Right. I will take over.
Yeah.
So if you see, this is an aggressive lesion once again. You can see that there is a lucency, there is cortical destruction in this. So once you get an aggressive lesion, according to the age, your differential changes.
Yeah.
Please remember multiple myeloma. Can this happen in 15 years old?
No.
Yeah, so that's a take-home point. The examiners want you to tell the differential diagnosis in this case. So please remember, you have to tell them according to all of these factors. So so that was one point to remember. Now this particular case, there is a CT which is irrelevant. I just wanted you to do it as a practice. Same. This was again osteomyelitis, but having said that, the idea was to see or to practice the differential diagnosis. And this is focal rib lesion, solitary or multiple in an adult, and then the same thing in a child. But please remember that the differential diagnosis should be confined to the age.
Any aggressive lesion in the child, the top two should be infection, but with Ewing's, we wouldn't get that destruction, isn't it?
No, Ewing's can, you see in Ewing's what can happen, there can be lot of destruction also, and soft tissue component can be, you can go into the fine touch. You can tell the examiner that because of these factors, Ewing is less likely, but you have to consider it, right? And then disregard it. So that's a bit of fine touch. Okay, is this an aggressive lesion or a non-aggressive lesion?
So it looks like an aggressive lesion because there is surrounding periosteal reaction. It has a wide zone of transition surrounding periosteal reaction. Almost looks like there's a Codman's triangle on the medial aspect. So the features are in keeping with an underlying aggressive lesion. In a 48-year-old, my differentials would again include a METS, a myeloma, infection, and lymphoma.
Lymphoma should be up there. Yes, lymphoma should be up there. Okay.
And
myeloma, you have to keep it down. Even 48 is a bit young for that.
Okay.
Any case, so that was another. And one thing is that will you keep osteosarcoma in your differential?
So looking at the location, it's osteosarcomas tend to be because of the age group, but then osteosarcoma can have an adult onset as well. The location is not metaphyseal, and but the way the periosteal reaction is almost looks like an onion skin. So I'm lamellated, so I might keep it in a differential, looking at the periosteal reaction.
Right. So literature tells you that osteosarcomas in 10% of cases, maybe 8 to 10% in some series, might be diaphyseal even. So there is a concept of diaphyseal. But you tackled it well, where one of the major discriminators is age, and you said fine, because sometimes unusual things happen at unusual ages. But otherwise, I was just trying to see the thinking, and the thinking process which you have demonstrated was fine. And this is what the examiners are going to. And at times they will grill you, why this, why that. They are just trying to see your thinking. Bone tumors we will cover, in the next session or next to next session. So we are going to skip it. So over to you.
Okay, so I've got a frontal and lateral radiograph of the lower limb of a skeletally immature patient, because I can see the epiphyses are not fused. And I can see there is a lucency in the proximal diaphysis and on the lateral with surrounding sclerosis, and the anterior cortical margin is quite thickened. On the frontal radiograph, I can see there is periosteal reaction, very subtle. So again, it's an skeletally immature patient. So I am thinking whether this is an underlying infection, and it's the process of infection which involves the involucrum and sequestrum. But again, I would include LCH in my differential as well.
Now, if you stretch your imagination slightly and see carefully, in the real world, you will be on a DICOM viewer, and you can play around with your densities. But do you see this? Look at the configuration. Isn't it linear?
Yeah.
So what comes to your mind?
So it can't be an LCH.
Right. Very good. So this.
It's more like a
yes,
infection.
Infection. And why do you say that?
Because I think it's the way the process works. You make the involucrum, then the sequestrum, and the layering.
There's a word which comes to your mind. I want to hear that word. Look at the shape of this.
It's a button. No.
Look at the shape. It is like a burrow. If a mouse goes into the ground, what does it do?
I totally forgot. It was in my mind.
Okay. I'll take over.
Yeah.
So this is what we call tunneling, right?
Yeah.
Cortical tunneling, and this is quite specific for infective process. Look here. It has tunneled through the cortex. It is going up and down. So these tunnels are pathognomic of infection. And this is a CT just to develop your eyes, and this is an MR. So in a way, it is an intramedullary abscess. But the point is that on a plain film, you can see that there is cortical tunneling and things like that.
Yeah.
Okay, rapid reporting case. I'm using the term rapid reporting, just so I'm giving you no description.
Okay. So
Tell
again,
me this is normal or abnormal. Just concentrate here.
Abnormal. Abnormal. There's a prosthesis and lots of soft tissue swelling.
Okay. What's happening there?
I'm not convinced. There's no like when we're looking at prosthesis, we won't look for periprosthetic loosening and want to follow the loosening.
So your thinking is absolutely right. Do you see anything there?
Not there's a slight amount in the distal femur where the prosthesis sits anteriorly, and then in the proximal tibia, it's got a slight there.
So this is a genuine finding and means that this is taken as a sign of loosening or an infection or whatever. This particular case.
It's 9 o'clock.
The point is that if you see this lucency, call it.
Yeah.
This is a too simple a case, and this is just give me without description. Tell me what is your diagnosis.
So the C5 vertebral body on the lateral. There's some, and so the C6 vertebral body has lost its superior margin, and the C5 vertebral body, there's quite a marked amount of dislocation there because I cannot align, and there's facet joint dislocation as well. So the facets are locked because drawing my anterior spinal line, there's a disruption at the level of C4, C5, and then I can see there's some disruption of the vertebra there, an avulsion fragment, and underlying mixed lucent and opacified lesions. I'm thinking there's a destructive process going on at that level, which is causing significant subluxation. But looking at the AP view, the spinous processes are aligned.
So don't worry about the AP. Everything is on the lateral. And what
There's
about
extensive soft tissue, prevertebral soft tissue swelling at that
so
level as well.
Anything else? What is your conclusion?
So this could be secondary to trauma.
There is no history of trauma.
This could be secondary to vertebral osteomyelitis, vertebral body osteomyelitis.
Why do you say that? Why do you say that?
Just
Because the simple reason is that we are doing a chapter on infection.
The way the margins are irregular, just
right.
like this disruption of the end plate superiorly. And usually when
What is happening to the intervertebral disc?
We've lost the intervertebral disc. So
that is the key. So I'll take over, please. Yeah. So that is the key. Whenever you describe something in the spine, intervertebral disc should be, one of your pertinent negatives or positives. See what is happening. In this particular case, the intervertebral disc is not present. Tells you, please remember that intervertebral discs are lost due to infections and not because of malignancy. So with that, everything else is also, and plates are destroyed from here to here. This soft tissue anterior to the lower, those of you who are ST1s, if you open a textbook, it will give you measurements. But one of the formula is that anterior to the lower cervical spine, they say just eyeball it. Anything more than the depth of the vertebral body, for example, that is abnormal. So there is a lot of soft tissue, means there must be an abscess. So this is TB of the spine.
So,
TB of the spine, then
the discs are preserved initially and it starts in the body. With TB, because I initially thought about you, but then I thought the discs are usually preserved early on and then.
No, so but why are you? Have you got this concept that you will not get destruction in TB?
No, we do get it, but not as much as compared to pyogenic osteomyelitis.
No, that is just a relative thing. Nobody is expecting you to pick up that this is a TB spine. You should have called it spondylodiscitis, right?
Okay.
Means infection. And then TB or pyogenic is a different word. And usually we are not very good there to differentiate. Books will tell you differentiations, but they are very subtle or non-specific. Basically, this is infection, and your case is finished. So this is multiple collapsed vertebrae. The differential diagnosis and infection is there, and the key finding in infection is that the intervertebral disc is gone. Yes, please.
So I've got a frontal and lateral radiograph in a 45-year-old female, and I can see that there is a lucency projected over the over the distal radius, which has a well-defined margin. And on the lateral, however, I can see there is a periosteal reaction, the appearance of which is like a sunburst periosteal reaction. I cannot see any fracture or dislocation, and the carpal bones appear unremarkable. So in a 45-year-old female with an aggressive looking lesion in the distal radius, my differentials would include METs, which in the case of a female could be from breast, lung, and there are others as well. And second would be infection. And then I'd also include lymphoma or a primary bone tumor.
What kind of
primary bone tumor? Less likely, but METs, lymphoma, and infection.
is there any primary bone tumor which can give you this kind of appearance?
No, so I take that back. I don't think it's a primary. If it was a child, I'd be thinking about a primary bone tumor, but I've never seen, like, it was only on the lateral, the way the periosteal reaction is, but on the frontal, I don't think it looks more
Okay,
like.
in your, this is the differential diagnosis, which is I wanted to show you a differential here, which is what we call subarticular lucent bone lesion. Subarticular lucent bone lesion is in your Chapman.
Yeah.
And this is subarticular lucent bone lesion, extremely important for your exam. And there are primary bone tumors, this. And both of them, they will come in the exam. In a child, chondroblastoma. In an adult, giant cell tumor. So giant cell tumor is classical. This is a classical location of a giant cell tumor. And what happens is that giant cell tumor is slightly eccentric. It has got no sclerosis, marginal sclerosis. Of course, usually it doesn't have a periosteal reaction, but you should have, for me, giant cell tumor will be the primary differential in this case, other than infection.
Yeah.
Spot diagnosis, 30 seconds.
So this calcification.
Something
I think the word, the lower lumbus, the lumbar spine, and then there's adjacent calcification. I'm thinking whether these are paraspinal abscesses secondary to TV of the spine.
Excellent. So this is, just historic, something which is there, which had happened in the past, bilateral psoas abscesses, which are partially calcified now. And there is what we call a gibbous deformity. Even here, you can see that destruction, this intervertebral disc is gone, things like that. Okay. These are the normal sequences of the spine. So this is particularly for ST1s. When we do spine imaging, so these are the kind of sequences which we can do. We don't do all of them in each and every case, but you see this is a T2 weighted sequence, and this is a T1 weighted sequence. And this is a stir sequence. The same thing, and short tau inversion recovery. Please remember, by definition, stir is a fat saturated sequence. So it will show edema, etc., very well. And this is a T1 fat saturated sequence, pre-contrast, and this one is a post-contrast. So whenever we do a post-contrast in the spine, we do it with fat saturation. Now, you have to develop your eyes that how does a sequence look like, and you can see that on a T2 weighted sequence, how is the marrow. Now, look at the marrow here and develop your eyes on this. Look at the marrow of the spine, and you can see that this is high signal on T1. Now, this high signal on T1 is because of fatty component, and this will change according to the age of the patient. In a young child, this might not be as high as this patient. Having said that, it should be more than the intervertebral disc. So that is a very, very important point to remember for your exam. Anything which is lower than the Candidate 2, over to you.
So I've got multiple sequences through the lumbar spine of a 22-year-old, axial and sagittals. And on the T2 weighted sagittal, I can see there is the intervertebral disc appears irregular. With surrounding low signal, which on the stir shows diffuse edema spanning both the vertebrae and the intervertebral disc, but not much in the post-vertebral muscles and not much in the anterior space. Then looking at the T1, this is low signal on T1, and post-contrast enhances. So on the axials, I cannot see anything in the paravertebral regions, like looking at the muscles. So basically, I've got disruption of the intervertebral disc at L5S1, loss of the end plates, and low T2, high T1, low T1, high T2, evidence of edema on stir and post-contrast. So these findings, given the history of fever as well, would be in keeping with osteomyelitis.
Okay, fine. Thank you. And candidate 2, if you can mute yourself. Thank you. Now, if you see here, look at the intervertebral disc, high signal, there is high signal. And this high signal also, and the disc is on this T2 weighted sequence, disc has got irregular outline. You know, remember the term spondylodiscitis. So usually infections, they begin in the intervertebral disc, and from there they will go into the adjacent end plate. So there is a bit of destruction of the adjacent end plate. And on a stir sequence, now this is a look at this marrow of this T1 weighted sequence, and you can see it is black, and portion of it, particularly which is next to the intervertebral disc, is blacker than the disc. And this is abnormal. Compare it with the stir sequence, and stir will be high signal, means that there is edema, bone marrow edema is there. This, you can mute yourself, please.
Love you.
So, on the post contrast, remember that the intervertebral disc is enhancing. If there was a fluid component as an abscess, that will not enhance, that might not enhance. So phlegmon, this word should be in your vocabulary. When you give contrast in infection, if it enhances, consider it an inflammatory mass which is enhancing. Please remember, pus or component will not enhance. And that is very important, because in various, for example, in liver, if there is a liver abscess, the clinicians will ask you, can you put in a drain? So please remember, if it is not liquefied, you cannot put in a drain. Similar question they will ask you in spine or in head and neck, as in subperiosteal abscess. And these are exam questions. So please develop this concept of phlegmon versus abscess. Phlegmon is inflammatory mass which will enhance, and abscess will be pus which will not enhance. So here everything is enhancing. Till now there is nothing to be drained. And again, you can see that there is a concept of bone marrow edema, and bone marrow edema also enhances on contrast. So this is spondylodiscitis. So now we will take a 5-minute break, and after 5 minutes we will be back. Thank you. Right here, let me change this mouse to arrow. If you see it here, you can see something sitting there, and then it shows enhancement here. What do you think is happening? How will you call it in your report? What is this enhancement? What is the word which you are going to use for this?
It's I'd say it's meningitis of the.
No, please remember that basically it is an spondylodiscitis, right? So there, spondylodiscitis, same like previous case, and this is what is an inflammatory phlegmon. You are right that the dura must be involved, but basically it is, don't use the word meningitis here, it is a phlegmon, which goes with this. And the clinical question will be that is, can you put in a, take a sample, put in a drain and things like that. And this is what I was telling you, that if it is not liquefied, then you cannot do that.
Yes.
So this is an aunt mini type of a case. If you have seen it, you will call it. If you have not seen it, you will find it very difficult. So over to you.
It's a enchondroma. It's an expansile lesion affecting the entire first metacarpal bone with chondroid matrix.
Where is the chondroid matrix?
Distal
You see,
half,
yes, please. Yes, please.
the distal half of the lesion.
It is. It is what we call sclerotic. If you see here what is happening, look at the age. It's a young age group. Of course, in some of the syndromes, which we will learn next time, enchondromas can happen. Enchondromas usually are not as expansile in the metacarpals. They will be lucent. Chondroid matrix is calcification. They will be lucent lesions. This thing is not lucent. It is causing expansion of the bone like anything. And this is a specific diagnosis known as spina ventosa, TB dactylitis. And this is another case here. I think it's a German word, if I'm not wrong. Ventosa means a short bone with expansion or ballooning. And historically speaking, interestingly, spina ventosa was the first diagnosis of a disease made on a pediatric age group, historically speaking. So this is a particular type of TB, spina ventosa. This is a aunt mini case. If the problem with aunt mini cases is you can see a bit of periosteal reaction here also. That if you have seen it, you will never forget it. Usually in FRCR exam, now they do not show aunt mini cases. Having said that, nobody is stopping them. So you have to know aunt mini cases also. Yes, please.
Okay, so these are frontal and oblique plane radiographs of the right distal foot, showing lace-like destruction of the distal phalanx of the first toe and the proximal phalanx of the second toe. My top of differential for this appearance is sarcoidosis.
Excellent. Now, this is a pathognomic case of sarcoidosis. Sarcoidosis has come in the exam many a times. And please remember that this can also come as a long case. For example, this case with some finding on a chest X-ray or a CT of the chest. Sarcoidosis is a whole body type of a, even neuro or head and neck, and so many manifestations of sarcoidosis are there. But in the bone, there are many, many, many patterns which can happen. But this is one of the pathognomic ones, and usually this will involve the feet or the hand. The classical pattern where you can see punched out lesions, we use the word punched out lesions, giving you at times a lace-like or reticular pattern. So this is sarcoidosis, and these are two different examples of hands. If you can see here, look at this very, reticular lace-like pattern. Something is sitting here and here also. The film is not very good quality, old film, and these are other lesions. So consider sarcoidosis whenever you see these kinds of lesions, hand or feet. Well done. Now, this is distal phalangeal destruction, is a differential diagnosis. And in that, you can keep sarcoidosis also. Yes, please.
Right, so this is a plain frontal radiograph of the lower limbs of skeletally immature patient. I assume an infant or a neonate even. So I can see bilateral symmetrical generalized preosteal reaction, linear preosteal reaction. I can also see medial metaphyseal destruction on both sides, more on the right side. I cannot see any other destructive lesions or fracture lines, soft tissue masses, or any other abnormality. There is mild bowing of both legs. So my differential diagnosis is maybe sometimes it's etiological, but I don't think so because of this metaphyseal destruction. Sometimes maybe Caffey's disease. I can't really proceed with it.
Okay. Now, I'm going to take about 20 minutes to talk about this case. And this case, all of you, particularly the juniors, I want you to really concentrate on this case. This is one of the favorite cases which I take as an example. And the point is how to tackle a case of differential diagnosis in the exam. As we proceed further, we'll come back to these points again and again. But this particular case, tackle it as an example. So what I'm going to do is that I am going to come out and I am going to go into by the way, this case, before I come out, I just wanted to tell you that this actually is syphilis. Why is it syphilis and things like that? I will show you. Syphilis, by the way, as this news tells you, has gone up in the Western world. So let's go back. Candidate 3, can you see my screen, the distinction student approach?
Yes.
Yes?
Yeah.
Okay, so you can mute yourself. Now, this is a differential diagnosis of periosteal reaction, bilateral symmetrical in children. So in your book, if you open your book, page 450, there is a differential diagnosis of periosteal reaction, bilateral symmetrical in children. And please remember that there will be a separate differential diagnosis for adults. Now, in the differential diagnosis in Chapman, anything which is underlined means that it is very important for your exam, and this is less important. But two things from my side you can add there, which are, I think, deficient: non-accidental injury and vitamin A toxicity. If you can add this in the list. Now, what I'm teaching you is basics, and this is for ST1s. When you in radiology, and you will take about 2 years to develop these skills. Differential diagnosis is very important. First thing is that you have to learn the differential diagnosis. From Chapman, we are talking about lists here. And to learn lists, the best method is to, they say that radiologists always hunt in pairs. So make a study partner and you have to ask each other. So remembering of this differential is extremely important. On this film to tell the age of the patient. Femoral capital epiphyses, remember, are exam epiphyses. They will always help you. What is the age? So femoral capital epiphyses about 7 months, but literature tells you anytime between 4 and 7 months they will appear. So there is no femoral capital epiphysis. Means this patient, this is younger than 4 months or so. Now, then what is happening? That there is periosteal reaction. Periosteal reaction goes along the diaphysis, extends to the metaphysis. Look at this erosion, and particularly look at this erosion and this erosion on the medial side of the tibia. And then there is periosteal reaction here, bilateral symmetrical. And this is classical for congenital syphilis. We'll come back to this. Why is it classical? But look at the other differential, normal infant, and all of these things. Let's go through them. First of all, a few things. Age, juvenile idiopathic arthritis. This is not the age group, not at all, never. Usually these are teenage, or even if they are, young, they might be 7, 8 years old. And this there is, if you go back to the normal metabolism of bone, there is osteoblastic and osteoclastic activity going on. Under the periosteum, there is new osteoid which is deposited. So in rickets, what happens is that that osteoid is deficient of calcium. So it is low density and giving you this pseudo appearance of a periosteal reaction. But what have you learned from this case? Look at the metaphysis and there will be cupping of metaphysis. So after rickets, and this is again page 614 of your, in your Chapman for ST1s, there are two parts. First part is differential diagnosis. Second part has got some good, conditions which are summarized there. And this is from your book. And it tells you what are the signs of rickets, etc. We will do it in 2 sessions down the road. We will come back to this. What happens in rickets? Now comes scurvy. So in scurvy, there is a what we call Wimberger ring sign. Scurvy cannot happen before 6 months of age. Remember that, because ascorbic acid or vitamin C, it goes from the mother to the baby through the placenta. After 6 months, scurvy can be there. In scurvy, there can be periosteal reactions, but there are other stigmata, which we will learn in detail later on. But having said that, what happens is that the epiphyses are sharp and sclerotic, and rest of the bone is osteopenic. So there is a sign which we call Wimberger ring sign. And in syphilis, there is a sign which is another sign. We'll come back to this, but remember this word, Wimberger ring sign. And so this is from the from your book, and which tells you various kinds of stigmata or various kinds of signs. Wimberger sign, reduced epiphyseal density with pencil-thin cortices. So, and there are other signs also, which I'm not going into details. And sometimes in scurvy, what happens is that there is subperiosteal bleeding, and it will cause periosteal reaction. Look at this case, 4th September 67 and 18th September, lot of periosteal reaction is there. And this is another case where there is a lot of periosteal reaction. And you can see this Wimberger sign and Falcon spurs, etc. Then in your book, there is a differential diagnosis, prostaglandin E1, prostaglandin therapy. So this is a case from literature. You will give prostaglandin to patients who have got cyanotic congenital heart diseases. And this is a very good example from Radiopedia, where this is at birth, and they started giving prostaglandin, and after 3 weeks, you can see all of this periosteal reaction. But you will agree that there is no metaphyseal erosions or things like that. So then comes NAI. NAI is non-accidental injury. And in NAI, what happens is that there is metaphyseal fractures. So there can be periosteal reactions which are at various ages. So this is metaphyseal fractures. And finally, vitamin D toxicity at times can happen with periosteal reaction, never ever before 1 year of age. So, so the point is that this is a typo. This should be vitamin A toxicity. If you can correct it, it is vitamin A toxicity. So the point is that once you know all of this, then in your description, you yourself, so the bottom line is that a distinction candidate will tackle it like this. And now concentrate on how I'm going to tackle it. That the candidate immediately sees the age of the patient and then starts describing the findings. And the differential diagnosis comes to his or her mind. And then start narrating the pertinent negatives or positives uh, during the description. So in this particular case, this is a lower limb X-ray AP view. I cannot see the head of the femora epiphysis bilaterally. So the age of this patient is less than 6 months of age. I can see bilateral symmetrical periosteal reaction along the femora. It extends along the diaphysis till the metaphysis. On the medial side of the metaphysis, there are erosions bilaterally, more marked on the right side. And similarly, there is bilateral symmetrical periosteal reaction at tibia as well as fibula. Again, I can see this erosions, medial tibial erosions. And then start with the pertinent negatives. There is no Wimberger signs, there is no cupping of the metaphysis, and all of these things which can rule out all of the conditions which you will consider in the differential. And then finally say that this is in keeping with congenital syphilis, and in the same breath then advise. What are you going to advise? You are going to advise serology, VDRL, etc. So this is how you have to tackle these kinds of cases. So we will, as we go through again and again viva practices on various kinds of scenarios during the next 2 years. This is for ST1s. We will develop these skills. But my take-home point is that Chapman is the key, and you have to keep referring to Chapman. Right. So we finish this.
Dr. Khan, you're muted.
I was muted, so I will just repeat it, that this is the Wimberger corner sign, which is, don't confuse it with the Wimberger sign of scurvy, which is, regarding the sharp and crisp and sharp pencil thin cortex. Here, Wimberger corner sign is that there is a medial tibial erosion, but portion of this metaphysis is still seen. So this is for scurvy, congenital syphilis. Last case of this chapter, candidate 4.
Hello.
Candidate 4, can you are with us, correct?
Yes.
So if you can please tackle this case.
This is a DP radiograph of the right foot of a slightly mature patient. There is multifocal abnormality with absence of the bones distal to the metatarsophalangeal joint. Oh, I think you've clicked one ahead.
Hello? Yes.
Of the second to fifth rays, and those second to fifth metatarsals are tapered and diffusely sclerotic. There is also destruction at the great toe with loss of the terminal part of the distal phalanx and bony deformity at the first metatarsophalangeal joint. Overall, the appearances are of a destructive peripheral predominant process, and I would consider either avascular or neuropathic causes. So I would be considering arterial ischemia as well as causes of peripheral neuropathy.
So conditions like?
So in the latter, you put leprosy already, but I'd also be considering things like spine lesion causing a peripheral neuropathy, or metabolic conditions such as B12 deficiency.
Okay. You see, this is leprosy, and this is quite an Aunt Minnie type of appearance for leprosy. Now, in leprosy, what happens is that, just for your interest, this is BMJ of 1915. So, and 1915 BMJ, and they made a diagnosis of leprosy. Here you are on these X-rays. We have seen 2 cases of leprosy in our. So these are historic. That doesn't mean that this was an active disease or something, but this appearance of leprosy, you have to remember. Basically, there will be destruction of the joints. There will be erosions and destructions of the phalanges or toes and things like that. But there will be circumferential as well as longitudinal resorption of bone. Quite a interesting or pathognomic type of finding. And this is known as lipped candy appearance. Does not mean that all cases of leprosy will be like this, but this is a type of case in your exam. If you get it, call it lipped candy appearance leprosy. And leprosy has, please remember, we will consider Charcot joints next time, but this is one example of Charcot. And the bone density by definition in Charcot joints, it remains normal. Okay, this is a case which if an examiner has this case, he or she will show you. This is from literature. I've read about it. this is considered absolutely pathognomic. And in this, you can see that the digits are all eaten up, and you can see this calcification. And this is calcification of the digital nerves. So this is an Aunt Minnie type of a case, if somebody has it, but these kinds of films are now of historic importance. Only thing is that any examiner who might have it might show it to you. Right. We will, candidate 4, you please remain with us. I'm going to give you some minutes to do a feedback form. Those of you who have got a mobile phone, if you just scan this, it will take you to a web link to do a feedback form. And anybody who doesn't know, you can write this in this URL, this one here, and it will take you to a feedback form. So I am going to give you a 5-minute break here, and when we will join back candidate 4, I will again be with you. You can mute yourself, rather I am muting you for the time. So this is feedback time, please.
Epiphysis at the anterior tibia, nor is there separation from the adjacent metaphysis. There is a little bit of increased soft tissue thickness anterior to it, but it's certainly not prominent. However, if the clinical features were very, very convincing, i.e. there was pain localizing just to that location, the insertion of the patellar tendon, I might be willing to consider it.
Right. The basic point in Osgood-Schletter disease, what happens is this is the tibial tuberosity, and tibial tuberosity epiphysis can be fragmented as a normal variant. So please remember that. The basic thing is this soft tissue thickening. And if there is soft tissue thickening, of course, clinical correlation is paramount. Then you have to call it. Otherwise, you don't call it. That is the teaching. So the fragmentation of epiphysis is not the criteria. Soft tissue thickening is the criteria. Osgood-Schletter disease basically is a chronic trauma type of a scenario where in a growing epiphysis there is a traction epiphysitis where the patellar tendon is there. This is a more emphatic case where you can see a bit of fragmentation, but look at this soft tissue swelling. In your exam, particularly if you get this case in your viva, you will ask the examiner that I want to change the densities, and you can, if you make the soft tissue, then the soft tissue thickening will be more visible. There is another disease which is known as Sinding-Larsen disease, similar mechanism, and this is also because of chronic trauma, where you can see this is the insertion of the patellar tendon, and you can get this fragmentation, you can get this high signal on the stir sequence of MR. Rapid reporting, normal or abnormal? 30 seconds.
Abnormal, there's sclerosis of the second metacarpal head in keeping with Freiberg's disease.
Excellent. So if you see here, this is a classical film for rapid reporting. You can see this irregularity, a bit of sclerosis, classical location of Freiberg disease, which is avascular necrosis. Another example where there is collapse of the articular surface. Okay, thank you very much, candidate 4. Is candidate 8 with us? Is candidate 8 with us? No. Okay, candidate 6, please.
Yes. Hello.
Okay, rapid reporting. What is happening here?
I think the head of the fifth metatarsal, I can't see its cortical outline, so it's abnormal on a rapid reporting basis.
Excuse me, this is the, which bone?
Oh, this part, this is the navicular.
Navicular. So what's happening to the navicular?
There is like an extra bit medially that is not normally there.
So what has happened?
I think that could be congenital.
Right. If you see here, this is sclerotic as compared to this, right?
Yes.
So these are secondary changes. These are basically there is avascular necrosis of the navicular, and which is known as Kohler disease. Other examples here, which can happen. The idea is to just to show you Kohler's disease, and which is simple.
Okay.
Can you tackle this as a viva fill?
This is a lateral radiograph of the dorsal spine. There is preserved alignment of the dorsal vertebrae. One of the middle dorsal vertebrae shows decreased vertical height. There is also diffusely decreased bone density of all vertebrae. On the top of my differentials would be an osteoporotic compression fracture.
Okay, forget about bone density because that is projectional. The density is fine.
Mm-hmm.
But look at the age of this patient. Anything comes to your mind?
He's 18. I'm just trying to check the rest of the film.
Right. Don't worry, there is nothing else in the film.
Right.
Why did you raise the issue of osteoporotic fractures? Okay, and I've now also helped you that the bone density is fine. Can you reconsider that? Or if you are still considering osteoporotic fractures, then I want to hear the thinking behind it.
No, I just said that because I didn't see the patient's age, so that's my mistake.
Okay.
And the fact that you just mentioned that it's not there, so I agree could be the projection or the. But there is definitely decreased height of one of the vertebrae.
Right. Okay, let me take over. If you see here, look at this vertebrae. This is the vertebrae which you are talking about, I believe.
Yes.
That there is anterior wedging, the posterior height is increased as compared to this. But same thing is happening here. Look at this, and this is less. Same thing is happening here, and this is less. So at least these three vertebrae, and maybe this one also to a slightly lesser extent. With that, look at the end plates. Now, you will agree that the end plate has got this serrated type of outline, and the intervertebral discs are slightly reduced. Please remember, in osteoporosis, you will get biconvex intervertebral disc. That's a different type of picture. So this is different, and this is Scheuermann's disease, also known as adolescent kyphosis. And here what happens is, look at this picture and it explains to you everything. That there is what we call intravertebral disc herniations, as in Chamorro's node. And as the patient grows, the patient comes out of this condition and might become absolutely normal. Look at this MR. This is a different case, but just to show you the same thing. And you can see these multiple, look at this vertebra, just concentrate on this one. and see the same here, same thing here. This height is more than this height. And look at the end plate is irregular. And this is also the same thing, Scheuermann's disease. Please remember that Scheuermann's disease is in the differential diagnosis in your book. Multiple collapse for Scheuermann's disease. This is just for completion's sake because we are considering avascular necrosis. This is Blount's disease. I don't think so. Anybody will show you in the exam. But the medial epiphysis or metaphysis of the tibia is where it gets targeted. How will you tackle this, Phil?
This is an X-ray of the wrist focused on the scaphoid. There is a lucent line at the scaphoid waist, and the proximal scaphoid appears sclerotic. So there is AVN of the proximal scaphoid with due to a scaphoid waist fracture.
Right. So avascular necrosis, where the bone on a plain film, what happens is that this of the scaphoid classically is where the blood is, or the vessel is coming from here. So it gets disrupted, and on a plain film it will become sclerotic, while on a MR this is what is going to happen. So there is a fracture here which is not very well seen, but you can see that the proximal pole has got low signal on T1 and then high signal on this PD fat saturated. Rapid reporting, normal, abnormal?
I'm just checking. Abnormal.
What is the abnormality?
The lunate bone is totally collapsed and sclerotic. So that's an AVN.
So AVN of the lunate, and this can happen, and this has collapsed. Okay, thank you very much.
Thank you.
Is number 7 with us? Candidate 7.
Yes.
Over to you.
Okay. So it's MR pelvis, T1 and T2 weighted sequences in coronal views, which is demonstrating irregular shaped epiphysis of both femurs. There's also abnormal signal, which is low intensity signal on T1 as well as T2 in both of its bilateral epiphysis, femoral epiphysis. There's also some flattening of epiphysis especially on the left side. Appearances are quite suggestive of avascular necrosis of both femurs, head of femurs, or femoral epiphysis. I'm wondering if the patient is on any steroids, because it's a bit unusual to have bilateral AVN of both femoral head. I would like to compare with the previous X-rays as well, if there are any available.
And why do you want to do that?
Just to want to see the progression. If the X-rays are normal, for example, a couple of years ago, or even 1 year ago, and the patient history suggests the patient is on a steroid, that may suggest that the steroid has caused a side effect of steroid. The reason, we can find the reason if it has happened, if they were normal and then history suggests the patient is steroid. If not, then these are quite suggestive of avascular necrosis, basically on MR.
Okay, so let's go back a few learning points as far as your description is concerned. So look at the marrow and you go into the details of the marrow, there is a sign here which is known as, so just concentrate on the left side, and there is a sign which we call as double line sign. And double line sign is asked in the exam quite a few times. It has been asked. And another question is that double line sign, which sequence is it seen? So it is seen on a T2 weighted sequence. When there is avascular necrosis, please remember that we have created problems for ourselves. The word avascular necrosis is synonym with bone infarction. But in radiology literature, whenever it is subchondral bone, or subarticular bone, we call it AVN, avascular necrosis. And when it is in the metaphysis or diaphysis, we call it avascular necrosis. As correction, we call it infarction, but these are the same things. When there is bone infarction, then there will be abnormal marrow. And this marrow has got a geographical configuration. It is, these words should be spoken. Double line sign is a sign where you get a low signal here, and next to the low signal is the high signal. The concept is that the low signal is the signal between normal and abnormal bone, while the high signal, which is deeper to that, is granulation tissue. And this is a T2 weighted sequence which has got effusion also. Effusion. So this is avascular necrosis. Okay. Your second case, normal, abnormal.
Abnormal of medial femoral condyle. Okay.
Osteochondral defect here, or osteochondral lesion, whatever. Of the medial femoral condyle. And
a bit of, I think, maybe knee fusion as well.
Same case. Can you tackle it as a viva film?
Yeah. It's a knee.
So I've given you the diagnosis here. How do you describe this?
It's an X-ray APN lateral of a skeletally mature patient, demonstrating knee fusion. There's an OCD there's a sclerotic area of sclerosis in the medial femoral condyle, surrounded by lucency, which is demonstrating that there is an OCD which has not completely detached from its host site, and the sclerosis suggests that there may be a bit of AVN or necrosis going on in that detached, semi-detached or partially detached fragment.
Actually, the main question here is that the lucency, what does that lucency mean? That is the question, actually.
The lateral view, there is that lucency. So that lucency is the defect, I think, in the host site.
This lucency means that this is unstable lesion, and this will require surgery. It will not heal itself. That is the main concept. Okay, over to you once again.
Knee with fluid weighted sequence and fat suppressed T1. Which is demonstrating.
You are talking about this thing as fat suppressed T1?
No, this is fluid weighted sequence.
Okay, and this is
this is a normal T1. Which is demonstrating low signal, abnormal area of low signal in the medial aspect of in the cells of medial femoral condyle, which is returning high signal intensity on fluid-weighted sequences. There are also areas of abnormal signal in the tibia as well, left tibia, tibial metadiaphysis, with serpinous kind of opacific shadowing. I'm just wondering if these are in multiple areas of bone infarct. In fact, in the distal femur as well, bilateral distal femur, bilateral distal proximal tibias. So bilateral multiple bone infarcts are my provisional diagnosis here. There's a bit of knee fusion as well on the right side, especially.
Okay. So these are bilateral infarctions, and bilateral infarctions have got, again, geographical configuration bilaterally, and there can be many causes, even epiphysis, metaphysis, etc. All of these things are involved. So the point here is that look at the X-ray. And so in the exam, calcification within the bone or the medullary cavity of the bone is very important. And exam cases have come in this category. So if you see here, by the way, this is not the same case as this case. If you see here, look at the calcification and develop your eyes on the configuration of this calcification. And you will agree that this calcification has got a geographical configuration, because you have to discriminate it. And I will tell you with what. And bone infarcts are in the differential diagnosis of multiple sclerotic bone lesions. But look at this picture once again from a textbook, where you can see this geographic pattern of intramedullary calcification. Then you can see a cadaveric X-ray, same configuration, and of course similar on MR. Now, serpiginous calcification is classical for a bone infarct, but there can be punctate type of calcification at times. Punctate means dots. That can also happen. So, but exam calcification will be this type. Why is it important? It is very important because you have to discriminate it from this entity. This is enchondroma. Now, enchondroma, we will do it in the next session or the next session, is a cartilaginous tumor, a benign tumor, which 50% of them, they are placed in the small bones, particularly hand and feet. But others are in the other parts of skeleton, particularly the long bones. When they are in the long bones, you will not find any lucency there. You will only find their calcification. And this concept is known as chondroid matrix. So remember, on a plain film, chondroid matrix can only be seen as calcification. This calcification is denser than the bone, and that's why you are seeing it. Now, the main exam point is, look at the pattern of this. And this is how it is described in literature. Rings, arcs, punctate is dots, and flocculent means tufts of wool. So if you see, for example, this is a sort of a ring, and there are arcs, etc. And then this is the pattern. So what happens is, and both of them are exam cases. Please remember the take home. There is a concept of malignant transformation of enchondromas, and that will come in the exam. So enchondromas can convert to chondrosarcomas. And similarly, bone infarcts can convert into malignant tumors. And the examiner will ask you what has happened. So over to candidate 6, or who was, sorry, it was 7, isn't it?
7.
Candidate 7.
Yeah.
This is from literature, but a good case to stretch your mind. I want you to describe it very well. And all the audience should listen to this very carefully, because this is a wonderful case for the exam.
So these are the X-ray APN oblique or lateral view of tibia.
This was femur.
So femur, which is I couldn't see the fibula, so yeah, it's my mistake. Femur, distal femur, which is demonstrating aggressive-looking lesion in the distal diametaphysis with the wide zone of transition. There's also serpingeous geographic areas of calcification within the central medullary cavity. There's also expansion of the central medullary cavity and the breach of cortex in the lateral images. There's also some periosteal bone reaction as well, especially evident on the lateral images, lateral X-ray. Overall, the findings are suggestive of bone infarct with possible malignant transformation within it and the fracture through it. I would be very keen to compare with the previous X-rays if there are any available to see the change if a change of pre-existing bone infarct or a transformation into the malignancy. I would urgently refer the patient
What
back
else
to the
can it be other than a bone infarct with malignancy?
If the bone infarct is in chondroma is another suggestion, but in chondroma, you can get the expansion, and the expansion is there. There could be fracture through the chondroma, but I would not expect to see the periosteal reaction. Enchondromas can transform into the can have malignant transformation. In that case, periosteal reaction would be there. So the other differential in this patient with this presentation would be enchondroma with malignant transformation. These are my top 2 differentials. I would do MRI, although this is quite suggestive on the X-ray, but I would do MRI for the completion process and refer the patient to the regional sarcoma, MDT.
Okay, thank you very much. Number 7, you can mute yourself. Now, the point is that look at the pattern of calcification. Look at these words which I had: rings, arcs, punctate. Please remember the word punctate was also here in what we call the infarct. But this is the pattern, this is the pattern of what we call serpiginous calcification. Ring, arcs, punctate, and flocculent tufts of holes. So this is rings and arcs. Now, malignant transformation into a chondrosarcoma, when we will do the chondroid matrix, this is extremely important. What are the signs of malignant transformation of an enchondroma to a chondrosarcoma? Because please remember that enchondromas are sitting in the medullary cavity. When there is scalloping, you have to use this word for this. There is end-ostial scalloping. Please remember 2 words. End-ostial scalloping means something is sitting in the medullary cavity and then is causing scalloping of the cortex. Periosteal scalloping will be something sitting outside and doing scalloping here. When look at this, there is a lucency, then they say that if the scalloping is more than 2/3 of the thickness of cortex, in this case there is no doubt because there is a breach also. But the criteria, a more subtle criteria, is if there is more than 2/3 thickness of the cortex is involved. And another criteria is when the scalloping is more than 2/3 of the length of the lesion. These criteria we will learn once again when we do bone tumors. But this is the point is, this is what we call a story case. A story case are favorite in the exam. Story case is a story which the case tells you, and they come in the FRCR so often. The story is that there is calcification. The calcification has got a ring and arc or flocculent type of an appearance, means an enchondroma. Now there is a malignant transformation. Of course, you can keep it in differential. I will consider bone infarct, but the examiner is asking your thinking, and you will say that, you know, because it is not serpiginous, that is less likely. So this is a case of Casson's disease, divers, and in which what is happening, that you can see that there is subarticular sclerosis, and here also there is sclerosis, etc. And if you see the MR, you can see multiple bone infarcts. In Casson's disease, this is, these are divers who have got chronic infarcts and things like that. So is candidate 8 with us now? No. So candidate 5 is with us?
Yes, sir.
Okay, if you can please tackle this.
Okay, so I'm provided with the frontal projection of the skeletally immature patient, as well as the femur and tibia fibula frontal projection, in which I can see there is a pronounced periosteal reaction noted in the diaphyseal region, however sparing the metaphysis. On the frontal projection of the chest, I can see the similar finding in the humerus. There is a periosteal reaction as well, which is more pronounced in the diaphyseal region. So, and the rest, the upper mandible bone looks thickened to me. The heart shadow for the lungs parenchyma appear normal. So on the basis of this finding, my first differential on the 3-month male is the infantile hyperostosis, or I will, or rest, it could be an osteomyelitis, or so it's more like Caffey disease, infantile periostitis. So further, I will refer this patient to the pediatrician, the orthopedic, for the further management.
Okay, so this case, if you see, this is in the differential diagnosis, which I have already gone through when we were considering the syphilis case, bilateral symmetrical periosteal reaction. This is Caffey's disease, extremely important for the exam. And you have to understand that what kind of films can come in the exam and how you will tackle the viva. As I told you before, that it will, anywhere between 9 weeks to 5 months, this disease will initiate. Basically, there is periosteal reaction. Within the long bones, it is thick periosteal reaction. And it can be around the diaphysis mostly. But what is the pathognomic or exam finding? The exam finding is, mandible, maybe clavicle. So, and you can even ask the examiner that I want to see that, if it is not visible on the film, which he has shown you. And interestingly, what happens in Caffey's disease, that it resolves And gradually, there are two types which are given in literature, and one type actually resolves itself by about 1 year of age, and the second one at times by about 2 years. And at times, there will be some bowing of bones, etc., which will persist. So, if I will skip, periosteal reaction, bilateral symmetrical, we have already done it. And this is from literature, which tells you that at 6 months, this was the bone. 5 months, this was the bone. 6 months, this is, and then 12 months, it has become normal. In this case, the patient is 5 years old now, but you can see a bit of bowing and some thickening, which is persistent. This is the finding which I want you to remember for your exam. And examiner will show you this kind of film. They might start with this film. Look at this film. And just, you might be going right and left. Pituitary fossa is this, teeth are this. Actually, what is the finding? The finding is this. The finding is that this is the outline of the mandible. Look from here till here, right? But this is something extra. And this something which is extra is periosteal reaction, and means that this is Kefi's disease. So remember this film. This is from StatDX. And so other examples that there is periosteal reaction, and the medullary cavity that also becomes widened. Another example here. Another example here. Another film for you. Candidate 5.
So, okay.
So this is Kefi's disease. Let me tell you that this is Kefi's disease, and I'm going to give you marks for your findings. Please continue.
So I'm provided with the frontal projection of the chest and abdomen, plus the limbs of the skeletally immature patient, in which I can see there is, again, I can appreciate there is a periosteal reaction, thickened periosteal reaction bilaterally, and the long bones, and the clavicle as well. The ribs also shows the periostitis. So no evidence of any a fracture I can see in these views. I can't appreciate the digits in these are on the limited views. So maybe the fingers are absent.
Anything in the ribs?
Yeah, they are widened and thickened as well. The anterior ribs are like rose-shaped.
I said thank you. That is what I was trying to see if you picked that up. So if you see here, these are ribs, and you have to develop your eyes to pick them up, right? Ribs is very common. Clavicle is common. The mandible might project here, and this is where, in this case, you will ask for a, I want to see a mandible. That will be in your viva. And so this is a close-up of the same, and this mandible which shows, this irregular periosteal reaction, just like the previous case which I showed you. Yes, please.
Okay, that's the frontal view of the skull of 71-year-old male, in which I can see the pronounced thickening of the skull vault with thickened trabeculae, and however, the inner table appear normal to me, and inner table look regular, and rest of the and it appears sclerotic. So, and the the eyeball, the orbits appear normal. I can't see any abnormality in the mandible. So on the basis of this feature and with the age correlation, first differential is the Paget's.
Why do you think Paget's? Because of
7th age and its appearance because of thickened trabeculae and increased skull vault.
Okay. Anything else? Do you see this lucency here?
Yes, yes, bevel. Yes, I can see there is a lucency. So it could be LCH.
71 years.
Okay.
You want to see any other view?
Yes, I will go for lateral.
Okay, this is the lateral.
So on the basis of these images, I can see there is a lucency involving the frontal bone. It could be related to the Paget's lymphoma, or is the initial stages of the Paget's osteoporosis circumscripta.
Okay, good. Well done. Okay, just stop here and you can mute yourself. So this is Paget's disease. The key finding here was that you see this thickening and you see this lucency here. So this is, Paget's disease is an extremely important case for the exam. And those of you who are overseas, you don't see Paget's disease for the simple reason that Paget's disease is very common in UK and very common in, let's say New Zealand, Australia, some parts of Europe, and interestingly, and USA also, it's very common. But in many parts of Europe and Middle East, subcontinent, Southeast Asia, you don't see it. And there are various theories about Paget's disease. It's an old age thing and usually occurs anywhere post 55. In literature, some cases of Paget's disease have been described even under the age of 40, but I don't want you to remember that for your exam. Now, the key thing in Paget's disease is the concept that Paget's disease has got 3 phases: lytic, sclerotic, and mixed. And people do many mistakes because they do not pick up the lytic phase very well. And so remember that it can be lytic. There is more osteoclastic activity, and then there will be osteoblastic activity, and there can be a mixed type of thing. Enlargement of bone is what we are talking about. So these patients within the skull, please remember, there is involvement of the calvarium, which is this, upper portion, frontal bone, and the occipital bone, and the temporal bone also, the base of skull. And that's why at times the patient will present with, they will present to the doctor that the hat is not fitting in. And I remember one of my students, he was asked this in the Viva as a, key, that this patient has gone to the GP and he's unable to fit in the hat after many years. So that was the hint. Now, Paget's disease also can present, as far as the temporal bone is concerned, nerve palsies, etc., deafness, etc. Within the skull, you have to discriminate it with fibrous dysplasia, and we did cover it last time also, and we will cover it in head and neck. But one of the key discriminator is age. Second discriminator is that usually Paget's disease is calvarium and the temporal bone, while fibrous dysplasia is usually the facial bones, and if it is the base of skull, it is anterior base, sphenoid, etc. Second thing is that there is a type of fibrous dysplasia which we call Pagetoid type. in fibrous dysplasia also the confusion is that it can be lytic, it can be sclerotic, it can be mixed. So the page-toed type is something which you will find it difficult, but the main discriminator is age as well as the anatomical bones which I have talked about. Both of them can take uptake on nuclear scan, so that is not a discriminator. Now, as far as they will also show you complications of Paget's disease, malignant transformation and things like that. So let's see a few cases. So this case is nothing special, so I will just go through it. You can see whole of the skull wall, till the vertex, frontal and the parietal, as well as the occipital bone, everything, the temporal bone here. It is all Paget's disease. Is number 4 with us? Number 1?
Sorry, I am here, number 4, but we can go to
number 4. This is a very, very good case. Can you take up this?
Okay, I'm presented with frontal and lateral radiographs of the tibia and fibula of the right leg of a skeletally mature patient. There is an abnormality centered in the proximal part of the tibia, which is primarily composed of lytic change in the bone, mostly cortically based, but extending into the medullary cavity as well, with associated bony expansion. Inferiorly, this area narrows and narrows to a point, and thereafter the diaphysis more distally looks normal. There is perhaps some early trabecular thickening at the more proximal aspect, just distal to the tibial plateau. The appearances are in keeping with lytic, i.e. early phase Paget's disease.
Okay, so if you see here, the learning points in this case is, please remember one principle of Paget's disease is that it goes to the subchondral portion or the subarticular portion of the bone. So this is one principle of Paget's. But this principle is followed in tibia. So that is a key point to remember. And so the point is that here, if you see, this is known as blade of grass appearance, also flame shape, where there is a transition between abnormal and normal bone, and this is considered pathognomic for Paget's disease. And there is a lucency, and this lucency is what people find at times what we call confusing in the exam. And now it has not gone till the subchondral portion of the bone in this particular case. Now, this Diagram tells you that in Paget's disease, what happens is that there is thickening of the trabeculae. There can be thickening of the cortex, and which is visible on this case, both at the acetabular component as well as the femoral component. Thickening of the trabeculae is something which you have to develop your eyes for the exam. Look at this case and how Paget's disease has progressed from this lytic phase into the mixed phase, and now there is coarsened trabeculae as well as bowing of the bow. Examples of Paget's disease. So Paget's disease can also happen in metatarsals, but again, you see it goes till the subchondral portion of the bone. Another good example, basically there is thickening of the bone, enlargement of the bone, and it goes till the subarticular portion of the humerus. Number 4, please. Can you please tell me if there is a vertebra which is abnormal?
It looks like the L3 vertebra has reduced height.
Any vertebra which is larger? What do you think? A bit of stretch of imagination.
Well, maybe it's the other way, because I'm looking at one and comparing it to the one next door. So maybe L4 is bigger.
Right.
Okay. Oh, and actually the right pedicle of L4 in particular.
L4.
I think that's L4.
Okay. So this is, if this is L5, 4.
Okay, well then 3. Yeah, I'm looking at 3.
2. Okay. So we'll come back to this. Now, this is 5, 4, 3, 2. If you see here carefully, it's a subtle finding. So it's you know, the point is that this is a subtle case, but they have shown this kind of cases in the exam, where your eyes see what the mind knows type of a thing. They might show you Paget's like this, where one of the vertebra is larger as compared to others. And now if you have a debate, look at this versus this. This looks bigger actually than this, though I do agree that it's a subtle finding. Now on MR, this is the vertebrae, L2, versus these vertebra. Now, do you think that this marrow is normal or it is abnormal? Over to you.
It's definitely abnormal on these T1 weighted sequences.
So how will you call it? Are you worried about anything happening?
So if in a case of Paget's, my concern would be malignant transformation, which I think would also be osteosarcoma, sorry. In which case I'd be looking for cortical destruction, breach, soft tissue component, and other features of aggressive bone lesions. Some areas of the marrow here have reduced signal intensity, reduced compared to, for example, adjacent intervertebral disc or muscle.
But the point is, the main point here is that look at this. This is a T1 weighted sequence, and the marrow is bright. Even it is brighter than the rest of the vertebrae.
Yeah.
Bright marrow on a T1 is good news.
That's true.
Right. So the teaching or the learning point here is that, interestingly, can you imagine they have shown MR of Paget's disease in the exam? Now, if you read MR of Paget's disease from a textbook, it will tell you that there are no pathognomic findings. You know, findings will vary, which is common sense because the stages vary. But something which is given, which can be asked in the exam, is this case. on a T1 weighted sequence, at times what happens is that there is fatty marrow, which is even more fatty than rest of the bones. So we should not be worried about any malignant transformation, but the idea here was to show you one type of pages which can be asked as far as MR is concerned in the exam. Now, I am going to teach you marrow signals, and please remember we lost 10-15 minutes in the beginning. So and this is designed to last another 15 minutes. So those of you who are interested can continue, and entirely up to you, but because we lost 15 minutes, we will continue for the next 15 minutes, maybe 10 to 15 minutes. Now, candidate 4, this case is, now all of you, if you can concentrate on this, particularly ST1s and ST2s, and I'm going to teach you the marrow signal and how to pick up normal and abnormal. Now, this case is a case of multiple myeloma. We know that. This patient was sitting with a fracture of T12. We know that. Clinically, there is some progression of symptoms. They have done this MR, and if you are reporting it, what do you think? So I'm not at all interested in this vertebra. Forget about it. And what do you think? Is there any progression or not? That's my question.
Progression of the multiple myeloma?
Yes.
I suppose the question would have to be, how extensive was the disease before?
Before was just T12. Just T12.
Oh, okay. So it was known to be isolated.
Yes.
Because in that case, my concern is that the marrow signal looks
It's 11
diffusely
o'clock.
reduced on the T1 sequences.
Very good.
In essentially all of the vertebrae, and there are a few where it's a bit less.
And what are your comments on the stir sequence? This is the stir. This is the T1. This is the T2. So what are your comments on the stir sequence?
There's some high stir signal, I think, at the lower cervical spine.
Rest of the spine is normal. No?
So, well, I think the rest of the spine is abnormal.
Abnormal. Good. Now, you see, this is a very, very good case to learn. Now, this is a normal MR. This is a T1, this is a stir, and this is a T2 weighted sequence. Forget about T2, let's concentrate on T1 and stir. If you see this T1, look at the signal of this marrow. And you will agree that this is higher in signal as compared to the intervertebral disc. And on a stir sequence, what happens is that fatty marrow has to suppress. Suppress means that there, if there is water inside, it will become bright. Water means edema or something. Otherwise, it will become dark. So this is how a normal T1 and a stir looks like. Look at this case. Now, initially, it looks all, because it is diffuse finding, it looks like normal. Look carefully and look at the vertebral body, compare it with the intervertebral disc, and then you realize, oh, this is less than the intervertebral disc. Look at the stir, and if you have developed your eyes on the normal, then you will understand that everything is high signal. So there is a high signal on stir. Anything which is low on T1, high on stir means problem. It can be infection, it can be, anything infiltrated. So this was diffuse multiple myeloma. And this is a case which is a diffuse case of carcinoma lung. And in this case,
बेटा उस वाले रूम में जाओ ना तो बेडशीट ले लो डायनासोर्स वाली भी पड़ी हुई है उस वाले रूम में.
And in this case, what happens is that we can see the same thing. If you start looking at it carefully, look at this vertebra. and you will appreciate that it is higher in signal than the intervertebral disc. And then look at the stir. So this is exam case, and it has come in the exam. So develop your eyes on this. So this was the Paget's disease, and which is higher signal, we are not worried. And this is has been, in literature, they say that it can be high signal. There will be more fat than normal. What do you call this? I just want you to name this vertebra.
So this is like a picture box.
Picture frame.
Picture frame vertebra.
Picture frame vertebra is sort of a classical pathognomic finding for Paget's disease. Pathognomic means no differential diagnosis. In what happens is that, first of all, the vertebral body is enlarged. Enlargement of vertebral body is not a very specific finding. Other things can also enlarge a vertebra. But then there is coarse trabecular pattern. You're not very sure. But picture frame is something which does not happen in any other entity. This sclerosis and this sclerosis, there is nothing else in the world which can cause this. There can be sclerosis here and here, but not here and here. So this is picture frame vertebra, as in Paget's disease. Paget's disease can also involve the posterior elements, by the way. This is the trabecular pattern, coarse trabecular pattern on a CT scan. So this is picture frame. This particular, we will come back to this in the last few chapters when we have done renal osteodystrophy, Cushing's, osteoporosis we have already done, but we will revisit this. A few, bookish pictures which can come in the exam of vertebrae, but this picture frame you have to remember. Subtle case from StatDX, but I wanted to show you, and this is a very, very good case to develop your eyes. And so if you see, this is Paget's, and first, easy to miss, but then you see the subtle finding, it is enlarged, and the posterior spinous processes are also enlarged, and there are coarse trabeculation. So I just wanted to show you as an example of if an examiner has got it, he would like to show it to you. Another example where there is high marrow signal because of fat. This is fat, but this is a T2-weighted sequence. Similar example I've shown you, but that was on a T1-weighted sequence. Okay, rapid reporting, normal or abnormal?
There is abnormal, there's increased sclerosis in the region of the left acetabulum.
Excellent. Now, this is a type of case which has come in the exam many times, subtle findings, and usually it will be for Viva, this kind of a case. What is happening that if you see here and compare it with this, look at the trabeculae. So develop your eyes on trabeculae, and you will see this coarsening of trabeculae. And then you look carefully, and a bit of stretch of imagination, there is a bit of subtle enlargement of bone, early case of Paget's disease. And this is a totally non-specific finding, but just to show you what it is. Paget's disease will also come in nuclear medicine. I don't know much about nuclear medicine, and we have got a separate course for nuclear medicine. So we will cover it there. But one principle of nuclear medicine I want to highlight, which is that they might show you a nuclear scan, and principle is that you must correlate. You have to ask the examiner that I want to see the plain film. So for example, if they show you this scan and there is uptake, right? Then you tell the examiner, I want to see the plain film. And on the plain film, it is like the first case which I showed you, osteoporosis circumscripta and with thickened diploic space, and there is Paget's here also, and you can see this coarsening of trabeculae. I think last two cases are left. Is number 1 or 2 with us? Anybody of you?
Yep, I'm here.
So thank you, number 4 and number 1, over to you. Just give me a spot diagnosis because of the time factor.
Paget's with malignant transformation to
And why do you say malignant transformation?
The left pelvis appears to be very expanded and possibly some periosteal reaction.
Okay, not convincing actually. The point is, this kind of a case is diffuse Paget's disease. Whole of the trabeculae, etc., are thickened. There is expansion. If you see carefully, though maybe the film is not of very good quality. But in this particular case, diffuse involvement of more than 60% of the skeleton was present. Now, on this particular film, what is your spot diagnosis?
Banana fracture.
Okay, so if you see here, these are, fractures which are incremental fracture. One cortex is involved. The second cortex is not involved. Insufficiency fracture, but it's not a complete fracture. So this is one of the known, what we call complications of Paget's disease, insufficiency fractures. This has been confused in the exam by candidates, and that's why I'm showing it to you. So this is, what is this?
Fibrous dysplasia.
Say again, please.
Is it fibrous dysplasia?
Anything else comes to your mind?
So it's a child with increased patchy sclerosis.
Okay, hint. What do you call this appearance? Whole of the skeleton is abnormal. Hint is that there is a differential in Chapman. There is a word.
Is it bone within bone appearance increased?
No, if you see, whole of this skeleton is abnormal, right? Now, the point is, this is known as moth-eaten bone. There is nothing which is normal. And now, first of all, I just wanted to show it to you because diffuse Paget's disease has been, this type of film has been confused by candidates, particularly overseas candidates, for the simple reason they have not seen it, that this can happen. And the key finding is coarsening of trabeculae, age, and then enlargement of bone. On the other hand, this is a child, and everything is abnormal. And this is known as moth-eaten bone. And the top two should be up there: neuroblastoma, Mets, and leukemia. But other than that, lymphoma, etc., can also. This is moth-eaten bone. So this has been confused.
Okay, so frontal radiograph.
This is a known case of Paget's disease.
So there is diffuse aggressive periosteal reaction in the right hemipelvis, which is concerning for malignant transformation to osteosarcoma in the right pelvis.
Okay, so in this particular case, what is happening here? There is a bit of sclerosis, etc. You are not very sure what is happening here. Though the film quality is poor, it is from literature. But having said that, look at this spine. This is L5. Why is there bone here? There should not be any bone here. And what does it tell you? The most common tumor, which is malignant transformation in Paget's, is osteosarcoma. And osteosarcoma is a bone-forming tumor, and that is why it has caused this sclerosis, and that ossification is projected here. So this was malignant transformation of Paget's disease, which can come in the exam. Last case of the day is a beautiful case, and I warn you, it has come in the exam. So I am not at all interested here. I know that this is an osteochondroma, so I don't want you to describe it here. Over to you.
So there is hemiatrophy of the left pelvis compared to the right hemipelvis. There's also scoliosis of the spine convex to the left. I also note some surgical clips in the right hemipelvis. There's no evidence of any bone metastasis or any lytic lesions. There's no fractures in any of the imaged bones. My top differential would be, it could be radiation-induced atrophy of the left hemipelvis, given that he has surgical clips and he may be a cancer patient.
Which kind of cancer comes to your mind? 20-year-old male.
So the clips are projected over the right hemipelvis. In that age group, it could be something like leukemia or lymphoma, but it doesn't really account for the surgical clips.
Yeah, surgical clips, right or left, can be misleading because they might have, there might be lymph nodes there where they have removed it. In any case, I will just conclude this case, and you've done well. This is a difficult one, and I warn you that this has come in the exam. And if you go back, I'll describe the case to you. If you see this asymmetrical maturation, this 14.4, it can be hemiatrophy or localized, and hemiatrophy or localized atrophy. Radiation treatment in childhood. And what does it tell you? This is a classical example of a story film which tells you a story. So there is atrophy here, and you can imagine, look at these vertebral bodies, and you can, stretch of imagination that this is slightly less, AP or craniocaudal dimension is slightly less than that one. So this patient had actually a Wilms tumor here, which and with that radiation, which has caused this. So this has also come in the exam, and hemiatrophy. Otherwise, it becomes quite difficult to correlate. So, so thank you very much. And those of you who have not done the feedback, if you can use this, and I have already told you rest of the programs, 2 programs which we have put on the website are, next Thursday, we are going to continue with bone. We will go to arthritis and start bone tumors. And then on Saturday, the following Saturday, not this Saturday, we will do a session. Maybe I don't, I put 5 hours in the schedule, but it might be less than that. So we will finish bone. Now, in tandem, what we are doing is that we are discussing among ourselves and the faculty of A to Z. I will teach you MSK, CNS, head and neck, GIT, MRI, quite a few things. So I might continue with my own sessions, or we might schedule something. But those of you who are sitting the 2B exam, you have to be motivated. We will be utilizing at times weekdays after 5 o'clock and at times Saturdays. So give us feedback if anything else, any suggestions or things like that. I'll be happy to receive them. You know the email also of our secretary. Right now our communication is not all that well. I think later on we will develop something on that grounds. So today I believe that in the beginning there was a bit of a IT issue, but apparently after 13-14 minutes everybody got logged in. So we'll try to look into that also. So thank you very much, and I will keep this feedback form for next few minutes. Thank you.